Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Farah Fika binti Razwan, and for my study case presentation, my topic is about chronic lymphoid leukemia. Leukemia can be defined as a group of cancers that usually begins in the bone marrow and results in high number of abnormal white blood cells. Proliferation of hematopoietic stem cells of bone marrow resulting in the accumulation of abnormal white blood cells in bone marrow and peripheral blood. Chronic lymphoma leukemia is a clinically heterogeneous disease originating from B lymphocytes that can differ in activation, cellular group, or maturation state. It is also a disease derived from antigen-experienced B lymphocytes that differ in the level of immunoglobulin V gene mutations according to Chiarazi. B-cell chronic lymphocytic leukemia is the most frequent leukemia that affects adults and elderly, and it also characterized by various biological features and clinical outcomes. There are several types of chronic lymphoma leukemia. The most frequent histological type is diffuse large B-cell lymphoma, while lymphoblastic leukemia, hairy cell leukemia, high-grade T-cell lymphoma, and classical Hodgkin's lymphoma are rarely described according to D'Adona. Many patients with chronic lymphoid leukemia did not have any symptoms at first. As the cancer progressed, symptoms and signs might also develop. It might include fatigue, fever, lymph nodes become enlarged but painless, weight loss, night sweats, frequent infections, and pain in the upper left portion of the abdomen, which may be caused by an enlarged spleen. The causes of this leukemia might be due to the mutations in the DNA of blood that producing cells. Generally, DNA commands the cells about what to do. The changes tell the blood cells to produce an abnormal and ineffective lymphocyte, which then multiply until the healthy lymphocytes die. The abnormal lymphocytes accumulate in the blood and certain organs, which may be causing complications inside the body. They also interfere with the production of blood cells. Factors that can increase the risk of chronic lymphoid leukemia, including our age. This cancer is mostly occurring in older adults. Then white people are more likely to develop chronic lymphoid leukemia than other races. Other than that, family history. A family history of blood and bone marrow cancers may increase the risk as the DNA are passed down to the next generations. Exposure to chemicals like insecticides and herbicides have been linked to an increased risk of this cancer. Lastly, lymphocytosis due to a condition. B cells are increased due to monoclonal B-cell lymphocytosis. For some people with this disease, the condition might develop into chronic lymphoid leukemia. However, people have higher chance of developing cancer if they have both MBL and a family history of chronic lymphoid leukemia. Mr. M, a 64-year-old gentleman, incidental findings of lymphocytosis with no blood cell during his routine clinical checkup at respiratory clinic. He is also underlying with diabetes mellitus, hypertension, dyslipidemia, and bronchial asthma. He denied history of travelling recently, no fatigue episodes, but he was associated with low-grade fever on and off for few days before bone marrow aspiration procedure was done. He also added has loss of appetite and significant loss of weight. There is no hepatosplenomegaly, but right inguinal node is palpable. After the findings during his checkup at respiratory clinic, he was admitted at hematology ward for further investigation. Upon bone marrow procedure, few tubes of blood samples were collected from this patient for further laboratory investigation before he was discharged. Based on the case presentation, there were information and clues that can help the diagnosis for decision making. Firstly, the low-grade fever on and off and loss of weight are one of the symptoms of chronic lymphoid leukemia. Pathology Laboratory of Hospital Raja Permaisuri Bainu Ipoh processed few screening tests for these patients' blood samples, which is full blood count, full blood pictures, renal profile and liver function tests. The laboratory findings revealed that there was abnormal high count in white blood cell and lymphocytes in full blood count results, which indicates a lymphocytosis. The most important part of screening test is full blood picture test, as it can show the morphology of the cells. For these test results, it was reported that hemoglobin is mildly low and red blood cells are normochromic normocytic. The white blood cell shows leukocytosis with lymphocytosis, numerous abnormal lymphoid cells seen, which appear matured, and many smudged cells are also noted. Platelets are adequate. As for interpretation, features are suggestive of lymphoproliferative disease. For biochemistry tests, renal profile and liver function test results are within normal range, indicates there are no hepatosplenomegaly. From all these results obtained from screening tests, it was believed that this patient have blood disorders, so few tests were done to confirm the diagnosis, like bone marrow aspiration, immunophenotyping tests, and cytogenetic tests. Bone marrow aspiration procedure were done and all blood samples must be from bone marrow. Bone marrow aspiration and immunophenotyping tests were sent to Hematology Laboratory of Hospital Raja Permaisuri Bainu Ipoh itself, while cytogenetic test was referred to Hospital Pulau Pinang for confirmation. The bone marrow report shows that there are lymphocytosis with the presence of mature-looking abnormal lymphoid cell for 66%. These results are correlating with immunophenotyping test. Features are in favor of chronic lymphocytic leukemia. Then the findings for immunophenotyping test is EDTA smear shows that numerous abnormal lymphoid cells which are small in size with mature looking and having clump nuclear chromatin. Immunophenotyping was performed on bone marrow sample showed 85 to 87% abnormal lymphoid cells scattered at CD45 intermediate to bright with low SSC expressing positive CD19, CD20, CD5, CD23, CD200, CD22, CD43, HLA-DR and lambda. The impression of IPT test for this patient, its findings are in keeping with CD5 positive B lymphoproliferative disease and best fit with chronic lymphocytic leukemia. Lastly, cytogenetic test results shows normal count of chromosomes because there is no chromosomal abnormalities were detected by FISH analysis during disease progression. The cytogenetics results was G-bending cytogenetic analysis of cultured bone marrow shows a normal male karyotype with no significant cytogenetic abnormalities in all cells analyzed. B-cell lymphomas caused by chromosomal translocation which involving oncogenes frequently. Inducing lesions should exist in the progenitor clone because the monoclonal nature of the B lymphocyte that proliferate in this disease. Sometimes it can occur as the disease progresses. Deletion at chromosome 13 is the most common as it occurs more than 50% of cases over all the time, according to Chiorazi. The deleted region consists of non-transcribed gene and 2 microRNA genes. The 2 microRNA genes which are located at chromosome 13 was deleted or down-regulated in most cases of chronic lymphoid leukemia, according to Chiorazi. The frequency of this deletion shows that it confers a selective advantage, might predisposing B-cell clones to undergo additional mutations. For medication history, this patient also was referred to respiratory clinic as he have bronchial asthma. So this is the list of medicine that he has been taking for a few years. From the case study, Mr. M was confirmed with chronic lymphoid leukemia. It was encouraged for him to do extra precaution since mostly patients with cancer have low immunity. He is advised to receive treatment to prevent his cancer to become more serious. He also recommended to repeat bone marrow procedure after finish every cycle of his treatment to monitor the effectiveness of treatment that he is receiving.